Hi, my name is Lindsay Edwards, and I am a fourth-year medical student at Rosalind Franklin University. I will be presenting an ascending aortic aneurysm resection with total aortic arch replacement case done at Advocate Lutheran General Hospital. Open total aortic arch replacements are performed with impressively satisfactory mortality and morbidity outcomes despite the challenging nature of the procedure. Here we explore a specific case to discuss the likelihood of complications. An 80-year-old male with past medical history significant for hypertension, hyperlipidemia, and borderline diabetes presented to his primary care physician with increasing bilateral lower extremity edema. On echo, patient found to have a dilated aortic root of 5.8 centimeters. His white blood cell count was 7, his hemoglobin of 12.9, hematocrit 40.1, platelets 185, BUN 14, and creatinine 1.07. His CTA chest came back showing a 6.7 centimeter ascending aortic aneurysm, possibly involving the root, extending very close to the innominate artery, then narrowing and tapering down in the mid-arch. Mild to moderate aortic incompetence was seen. A sternotomy was performed and chest retractor was secured in place. The pericardium was opened and cradle suspended. The extent of the aneurysm was seen to involve the proximal and mid-arch, requiring circulatory arrest. A left groin incision was made, and the left common femoral artery was dissected out. The patient was systematically heparinized and cannulated using a 20 French catheter. Purse string sutures were placed in the right atrial appendage. An antegrade needle was placed in the ascending aorta and retrograde in the coronary sinus. The patient was placed on full bypass, cooled to 28 degrees Celsius, cross-clamped, and placed in Trendelenburg. The heart-lung machine was stopped, ice packs were placed around the head, and steroids were given. The aorta was transected in the distal area and then resected up to the level of the innominate artery. Cerebral perfusion catheters were placed in the innominate artery and the left carotid artery, and antegrade cerebral perfusion was initiated. The remainder of the arch was resected up to the subclavian. A 30 mm branched hemoshield arch graft was anastomosed to the proximal descending aorta using 2O-proline suture buttressed with felt. Bioglue and felt were used to seal this extent of the dissection. Cardioplegia was given every 15 minutes directly down the coronary ostia and/or in retrograde fashion. The heart-lung machine was then restarted and the patient was warmed to 32 degrees Celsius. The valve leaflets were excised and the coronary arteries were cut out on buttons. The sinuses of Valsalva were excised. The valve was sized to a 27 mm Edwards Lifescience Inspirius bioprosthetic valve, which was sewn to a 30 mm hemoshield graft to create a composite valve conduit. Pleated sutures were placed around the annulus. These sutures were then placed through the composite and parachuted down onto the annulus and seated. An opening was then made posteriorly in the hemoshield graft, and this left coronary button was anastomosed. Next, as the patient was being rewarmed, an opening was made in the anterior portion of the hemoshield graft using thermal cautery, and the right coronary button was anastomosed. The hemoshield graft was then anastomosed to the arch graft. The patient was rewarmed, a hot shot of cardioplegia was given, and the usual de-airing techniques were performed. The cross clamp was released, and the heart began beating. As the rewarming continued and with the heart beating, the innominate limb of the arch graft was anastomosed to the native innominate artery. Similarly, the left carotid was reconnected to the graft. The patient was then weaned from bypass without difficulty. He was decannulated, protamine was given, and hemostasis was obtained. He had a severe but brief reaction to protamine, dropping his blood pressure into the 20 to 40 range for about 2 minutes. His cerebral oximetry dropped to the 40 to 50 range. The femoral artery was reconstructed, a single bipolar ventricular pacing wire was placed, and the sternum was reapproximated using interrupted number 7 stainless steel wires. Total cardiopulmonary bypass time was 195 minutes. Total aortic cross-clamp time was 137 minutes. Total circulatory arrest time was 26 minutes. Head vessel ischemic time was 6 minutes. Estimated blood loss was 200 cc's. Of greatest concern during this procedure are the risks associated with both decreased perfusion and hypothermia. These include brain or spinal cord injury, as well as injury to the kidneys and lungs. These complications, however, are much lower than expected. Permanent neurologic deficits are seen at 3.4%, transient neurological deficits at 5.2%, irreversible spinal cord injury at 0.6%, renal failure at 4.1%, prolonged intubation at 15.4%. Overall, open total aortic arch replacements are considered safe with an overall operative mortality rate at 5.3%, despite cardiopulmonary bypass times being very high and aortic cross-clamp times as well.